Good afternoon to all. This is the second part of my seminar, uh, the Bethesda system for reporting of thyroid cytopathology. We already discussed the first of five diagnostic category. In this part, we will discuss malignant lesion of thyroid. And the chances of malignancy is 97 to 99%. The usual management is near total thyroidectomy or lobectomy. The first variant is papillary thyroid carcinoma and its variants. The first variant is classical papillary thyroid carcinoma. And the classical papillary thyroid carcinoma is a malignant epithelial tumor derived from the thyroid follicular epithelium that display papillary architecture and characteristic nuclear features. The criteria for diagnosis is the cells are arranged in papillae and or monolayer cells. Cellular swells or onion skin or cartwheel-like architecture seen. In large and crowded nuclei seen. Often they are molded type, oval or irregular shaped nuclei seen. Longitudinal nuclear groups seen. Intranuclear cytoplasmic pseudoinclusion are present and pale nuclei with powdery chromatin and thick nuclear membrane. The marginally placed micronucleoli in number are solitary or they are in multiple in number. Samoma bodies are also seen, multinucleated giant cells seen, and variable amount of colloid present. This is the picture of papillary thyroid carcinoma low power view showing the highly cellular highly cellular smear with numerous monolayer sheets and occasionally papillary like fragments seen. And this is the high power view showing the papillary thyroid carcinoma monolayer sheets with syncytial like appearance are characteristic features of papillary thyroid carcinoma. The flat sheets resemble those of benign follicular nodules. Attention to the nuclear feature is essential for this distinction. This is the high power view of papillary thyroid carcinoma shown monolayer sheets with comprising of cells with irregular nuclei that show the focal molding in arrow. This is the comparison between thyroid benign follicular nodule and papillary thyroid carcinoma. The left picture showing the benign follicular nodular goiter. The cells are monomorphic type and abundant cytoplasm and monomorphic type of nuclei, while the picture B is the papillary thyroid carcinoma showing eccentric nuclear group is present and some nuclei show the internuclear cytoplasmic pseudo-inclusion. So picture B is characteristic nuclear features of papillary thyroid carcinoma. This is the low power view showing the papillary thyroid carcinoma. The true papilla tissue fragment comprised of fibrobascular core lined by the neoplastic cells. This is a high power view of papillary thyroid carcinoma showing the neoplastic cells surrounded by fibrobascular core. This is the papillary thyroid carcinoma showing in architecture form or swell type. This is the papillary thyroid carcinoma. The picture A or left picture showing the intracytoplasmic pseudo-inclusion. You can see clearly these two cells are showing the intracytoplasmic pseudo-inclusion, and picture B is a large intranuclear cytoplasmic pseudo-inclusion seen but not as much clear as picture A. This is a high power magnification showing the papillary thyroid carcinoma. The two intranuclear cytoplasmic pseudo-inclusion are seen. This is also the picture of classical papillary thyroid carcinoma. In high magnification with frequently nuclear group are seen. This is also the picture of classical papillary thyroid carcinoma showing the multinucleated giant cells. This is also the classical papillary thyroid carcinoma showing the samoma bodies concentric ring lined by atypical cells with oval pale nuclei. The other variant of papillary thyroid carcinoma, the first variant is follicular variant or non-invasive follicular thyroid carcinoma papillary like features. The follicular variant of papillary thyroid carcinoma are mainly two types. There are microfollicles present architecture of microfollicles, or they may be in the macrofollicles. Uh, so here we will discuss the follicular variant of NIFT-B. The follicular variant of papillary thyroid carcinoma is completely or almost completely composed of small to medium sized follicles lined by the cells with variable nuclear feature of papillary thyroid carcinoma. It means the exclusive features are present of papillary thyroid carcinoma, but uh, mm, the architecture form is in follicular type. The non-invasive follicular thyroid neoplasm with papillary-like nuclear feature is an encapsulator of well-demarcated neoplasm with follicular pattern. Left picture, this is the papillary thyroid carcinoma with follicular variant. The left picture is showing the cells arranged, follicular cell arranged in the microfollicular pattern. They are the crowded, enlarged, clear or oval nuclei. The upper right picture showing the ultrasound uh, ultrasonography with nodule with blood margins, and right middle picture showing the HNE stent with low power view showing the correlating with infiltrating margin, and right lower picture showing the orphan ani type clear nuclei. This is also picture of NIFT-P. The left picture, the architecture form arranged in microfollicle. The feature are characteristically nuclear feature are characteristically with papillary like the eccentric nuclei present, and the somewhere features of nuclear groove and intracytoplasmic pseudo inclusion also seen. The uh, right upper picture showing the ultrasound with well circumscribed solute nodule, and right lower picture is showing the HNE stent with orphan ani type of microfollicle. The second variant of NIFT is a macrofollicular variant. And the macrofollicular variant is papillary thyroid carcinoma in which over 50% of the follicles are arranged as macrofollicles. Follicle measuring more than 200 micrometer in diameter. Criteria for diagnosis: the sample consists monolayer sheets of neoplastic epithelium or variable size follicles. Convincing nuclear changes like papillary thyroid carcinoma must be present for a definitive interpretation of malignancy. In contrast to conventional papillary thyroid carcinoma, the diagnostic nuclear features are often more subtle. The papillary features and some body are not seen. Abundant thin colloid or fragment of thick colloid may be present. This is the low power view showing the macrofollicles of papillary thyroid carcinoma with macrofollicular variant. The left picture of papillary thyroid carcinoma with macrofollicular variant. There is large sheet of tumor cells with crowded orphan ani type I nuclei. The right picture showing the internuclear pseudo inclusion is present in the large oval nuclei, not also the peripheral micronuclei. The other variant of papillary thyroid carcinoma is cystic variant. The cystic variant of papillary thyroid carcinoma that is predominantly cystic, comprising of thin watery fluid, abundant histiocytes and hypervacuolated tumor cells. Criteria for diagnosis of cystic variant of papillary thyroid carcinoma is the neoplastic cells are typically arranged in small groups with irregular borders. Sheets, papillae or follicle may be also present. Tumor cells look histiocytoid type. Macrophages often containing a hemosiderin. There is variable amount of thin or watery colloid. Convincing nuclear changes of papillary thyroid carcinoma must be present for a definitive diagnosis of malignancy. In contrast to conventional papillary thyroid carcinoma, fine powdery chromatin is usually less prominent. This is the picture of the cystic variant of papillary thyroid carcinoma showing the prominent cystic changes with numerous hemosiderin-laden macrophages. A small cluster of neoplastic cell has a smooth dense cytoplasm, and one cell has a large intranuclear cytoplasmic pseudo-inclusion. This is also the picture of cystic variant of papillary thyroid carcinoma. The most of the cells in this image are neoplastic. They have abundant granular cytoplasm, hence the histiocytes of classical nuclear features. And the other variant of papillary thyroid carcinoma is oncocytic variant. The oncocytic variant is a thyroid tumor with nuclear changes characteristic of papillary thyroid carcinoma but composed predominantly of oncocytic cells with variable architecture. The criteria for diagnosis: the sample is composed predominantly of oncocytic cell polygonal in shaped with abundant granular cytoplasm arranged in papillary sheet or microfollicle or as isolated cells. The convincing diagnostic nuclear changes of papillary thyroid carcinoma must be present for a definite diagnosis of papillary thyroid carcinoma. Lymphocytes are also absent or few in number. The left picture is showing the papillary thyroid carcinoma oncocytic variant. The loose, cohesive, polygonal to plasmacytic, oncocytic or Hurther cell have atypical clear nuclei with eccentric micronuclei, while the picture B is clearly showing the multiple small large internuclear cytoplasmic pseudoinclusion. This is the next variant of papillary thyroid carcinoma is the Werthin-like variant. The Werthin-like variant of papillary thyroid carcinoma is circumscribed thyroid tumor with papillary architecture and lymphoid follicles that resemble a Werthin tumor of the parotid gland. It is often associated with Hashimoto thyroiditis. The neoplastic cells have an abundant granular cytoplasm and the nuclear feature of papillary thyroid carcinoma. Criteria for diagnosis is the neoplastic cells are oncocytic and arranged in papillae and as dispersed cells. A lymphoplasmacytic background is present. The lymphocytes and plasma cells uh, permeate the fibrovascular stalk and are intimately associated with the tumor cells. Convincing nuclear changes of papillary thyroid carcinoma must be present for a definitive diagnosis of malignancy. The left picture showing the of the Werthin-like variant of papillary thyroid carcinoma. The left picture is aspirate show the papillary fragment in lymphocytic background. The right upper picture showing the fibrovascular core are engaged with the lymphocytes. The right middle picture showing the epithelial cells are also intimately associated with the lymphocytes. Um, and right lower picture of HNE showing the tumor resemble a Werthin tumor like salivary gland tumors. The next variant of papillary thyroid carcinoma is tall cell variant. The tall cell variant is an aggressive form of papillary thyroid carcinoma composed predominantly of elongated tall tumor cells with abundant dense granular cytoplasm and the typical nuclear changes of papillary thyroid carcinoma. Criteria for diagnosis: the neoplastic cells are most commonly polygonal with centrally located nuclei but can be elongated and cylindrical with an eccentric placed nuclei. They have granular cytoplasm with prominent cytoplasmic border. Some lymphocyte may be present. Convincing nuclear change of papillary thyroid carcinoma must be present for a definitive diagnosis of malignancy. In contrast to conventional papillary thyroid carcinoma, the nuclei tend to be large and more elongated. The nuclear chromatin is sometimes less powdery and more granular. The nucleoli can be prominent and centrally placed. Mitotic figure may be present. Samoma body are fewer in number. Internuclear cytoplasmic pseudoinclusion tend to be more frequent and more often multiple within one nucleus, imparting a soap bubble appearance to be nucleus. The left picture showing the small of papillary thyroid carcinoma tall cell variant. The elongated cell in loosely arrangement. The middle picture showing the cytoplasm is elongated with frequent nuclear pseudoinclusion and rare soap bubble appearance of nuclei in inset. The right picture showing the HNE with tall rectangular tumor cells with eosinophilic cytoplasm. This is also the picture of tall cell variant high magnification view. The soap bubble like internuclear pseudoinclusion seen. This is also the picture of papillary thyroid carcinoma tall cell variant. The tallness of these cells is readily appreciated. Then this is morphology is seen throughout the sample. One can raise the possibility of tall cell variant in the FNA report. Columnar cell variant of papillary thyroid carcinoma. The columnar cell variant is characterized by the columnar cells with hyperchromatic oval pseudostratified nuclei and supranuclear or subnuclear cytoplasmic vacuole, secretory type endometrium scene. The cells are typically arranged in papillae, but trabeculae and follicles can also be seen. The criteria for diagnosis is the smear are cellular and generally lacked colloid. The neoplastic cells are arranged as papillae cluster and flat sheet, sometimes with the small tubular structure. The nuclei are elongated and pseudostratified. Focal cytoplasmic vacuoles may be present. Convincing nuclear changes of papillary thyroid carcinoma must be present for a definitive diagnosis of malignancy. In contrast to conventional papillary thyroid carcinoma, the nuclear feature of papillary thyroid carcinoma, groove, internuclear cytoplasmic pseudoneurosis are much less prominent. The nuclear chromatin tend to be hyperchromatic rather than the pale or powdery. The colloid and cystic changes are typically not seen. This is the papillary thyroid. This is a picture of papillary thyroid carcinoma columnar cell variant. The left picture, the aspirate shows loosely cohesive spindle-shaped cells. The middle picture, the cytoplasm is bipolar and wispy and cigar-shaped nuclei have a few characteristic features of papillary thyroid carcinoma, while the right picture showing the HNE pseudostratified columnar cells with elongated hyperchromatic nuclei and scanty cytoplasm. The next variant is solid variant of papillary thyroid carcinoma. This variant is defined histologically by the presence of solid areas that lack papillae, follicles, and colloid storage and occupy at least 50% of the lesion. The neoplastic cell have a typical nuclear feature of papillary thyroid carcinoma. The criteria for diagnosis is smear are variable, cellular, and generally lacked colloid. The neoplastic cells may appear as a cohesive syncytial type, three-dimensional tissue fragment, microfollicular or trabeculae, or non-cohesive single cell. The nuclei usually show the typical nuclear feature of papillary thyroid carcinoma, but they may be less elongated and darker than those of conventional or classical papillary thyroid carcinoma. The true papilla formation with fibrovascular core are scant or absent. This is the picture of papillary thyroid carcinoma solid cell variant. The left upper picture showing the cohesive syncytial tissue fragment. The middle picture showing the microfollicular or trabecular pattern. The right picture showing the non-cohesive single cell pattern. All three patterns have characteristic nuclear features of papillary carcinoma, convoluted nuclear features. The next variant is diffuse sclerosing variant. The diffuse sclerosing variant is characterized by the diffuse involvement of one or other thyroid lobes, extensive lymphovascular invasion, numerous psammoma body seen, squamous metaplasia also seen, marked lymphocytic infiltrate, and prominent fibrosis seen. The criteria for diagnosis is the smear are moderately to highly cellular with scant or absent colloid. The neoplastic cells are arranged in three-dimensional ball-like clusters and cohesive clusters. Intermingled with inflammatory cell, but conventional monolayer syncytial and papillae cluster may also be present. The neoplastic cells are round, polygonal, or columnar with dense cytoplasm and distinct cytoplasmic border. Hobnail cells protruding from cell cluster are often present. In contrast to conventional papillary thyroid carcinoma, there is less chromatin payload. There are fewer internuclear pseudo inclusion seen and nuclear groups less than 50% of cases seen. Large septate or uniocular cytoplasmic vacuoles are common. Squamous metaplasia changes are common, and numerous lymphocyte and psammoma body are present in the background. This is the picture of the diffuse sclerosing variant of papillary thyroid carcinoma. The left picture showing the aspirate show the papillary fragment associated with psammoma bodies and lymphocytic background. The nuclear chromatin is darker than the conventional classical papillary thyroid carcinoma. The right upper picture of H&E showing the thyroid gland, showing the numerous lymphoid follicles and many small holes, and the right lower picture showing the holes are from popped out from the samoma bodies. This is also the picture of diffuse sclerosing variant of papillary thyroid carcinoma. The neoplastic cells in this image showing the squamoid, they have a flat polygonal shape with sharply demarcated cell membrane, and they fit together like jigsaw pieces. This squamoid appearance is sometimes encountered as a focal finding conventional of papillary carcinoma. But in the diffuse sclerosing variant, this features is often widespread, not that dense cell lack of. The next variant is cribriform modular variant. The cribriform modular variant of papillary thyroid carcinoma is characterized by cribriform and solid architecture, the lacking of colloid. The cells are tall and columnar or spindle shaped, or squamoid morula are present. The tumor cell nuclei are often hyperchromatic and pseudostratified, although typical nuclear features of papillary thyroid carcinoma are also found. The some nuclei within the morula contain a peculiar nuclear clearing caused by the biotin accumulation. The criteria for diagnosis: the smear are hypercellular, colloid is absent, the tall columnar neoplastic cells have a papillary-like arrangement, the round to oval slit-like empty spaces formed by the spindle to ovoidal cells within cells cluster are present, or architecture pattern of cribriform. The cells cluster with ED formation are present. Spindle-shaped tumor cells are present in the background. Pale stain nuclei with thickened nuclear membrane is present. Nuclear groove also present, but intranuclear cytoplasmic pseudo-inclusion less common than the classical papillary thyroid carcinoma. Foamy or hemocyanin-laden histiocytes are often present in the background. Hyaline material can be seen within cell cluster or in the background. Samoma body and multinuclear giant cells are also absent. The neoplastic cells show nuclear and cytoplasmic positivity for beta catenin. This is the picture of cribriform modular variant of papillary thyroid carcinoma. The left picture showing the aspirate show large fragment of cohesive epithelium with a complicated arrangement. The inset picture showing the nuclear chromatin is dark, but nuclear pseudo inclusion are present. The right upper picture showing the H&E showing the tumor is characterized by cribriform morula formation, and right lower picture showing the higher magnification showing the characteristic morula. The next variant is Hobnell variant of papillary thyroid carcinoma. This variant characterized by the loss of cellular polarity and cohesiveness with apically placed nuclei and bulging of the apical cell surface. Hobnell features like in more than 30% of neoplastic cells. The criteria for diagnosis is the neoplastic cells show loss of polarity and cohesiveness, single cell with eccentric nuclei and tapering cytoplasm. There is a comet or drop like presentation seen. Neoplastic cells with an apical or eccentrically placed nucleus can be seen in papillary or micropapillary clusters. Multiple show bubble-like intranuclear cytoplasmic pseudo-inclusion seen, and typically nuclear feature of papillary thyroid carcinoma are present. Cell block may be reveal papillary or micropapillary fragment lined by the Hobnell cells. This is the picture of Hobnell variant of papillary thyroid carcinoma. The left picture showing the tumor cells with variant are characterized by the eccentric location of the nucleus in elongated cytoplasm, Hobnell-like pattern. The right picture showing the H&E showing the similar features. The next malignancy is medullary thyroid carcinoma. According to the National Cancer Institute surveillance epidemiology and results, the database medullary thyroid carcinoma comprises approximately 1 to 2% of all thyroid carcinomas. The medullary thyroid carcinoma occur in the sporadic hereditary form. The sporadic medullary thyroid carcinoma contribute 70 to 80% of all cases. Um, uh, they are solid thyroid nodule in adults. In contrast, patients with hereditary medullary thyroid carcinoma usually develop multifocally bilateral thyroid tumors, and the age of presentation varies with the syndrome. This is the table of pathological feature and hereditary and sporadic medullary thyroid carcinoma. Uh, there is three hereditary form: man 2A, familial medullary thyroid carcinoma, and man 2B. The sporadic medullary thyroid carcinoma is the sporadic form of medullary thyroid carcinoma. The proportion is the man 2A contribute 20% of all 20% of all medullary thyroid carcinoma, while 80% contribute of the hereditary form. The familial medullary thyroid carcinoma contribute 4% of all medullary thyroid carcinoma, while 15% contribute from the hereditary cases. The men to be contribute 1% of medullary thyroid carcinoma, 5% contribute for hereditary cases. Sporadic medullary thyroid carcinoma contribute 70 to 80% of medullary thyroid carcinoma. The age presentation is the men to a found mainly the third to fourth decade, while a familial medullary thyroid carcinoma found mainly in the fifth to sixth decade, meant to be present in infancy and children, and sporadic mainly seen at the age of fifth to sixth decade. The genetic all hereditary form meant to a FMTC and meant to be all are genetic mutation from germinal rat mutation, while the sporadic mutation seen from the somatic rat mutation. The inheritance all hereditary form inheritance by autosomal dominant trait, while sporadic are sporadic form of inheritance. Association of disease, the man 2A associated with the pheochromocytoma seen in 50% of cases, hyperparathyroidism seen in 20 to 35% of cases, and cutaneous lichen amyloidosis and Hirschsprung disease also seen in men 2A. In familial medullary thyroid carcinoma, they associated they mainly not show any these features like pheochromocytoma or hyperparathyroidism or endocrinopathy, any endocrinopathy. While meant to be a associated disease are this is the aggressive medullary thyroid carcinoma with early spread to lymph node, pheochromocytoma seen in 50% cases, mucosal ganglioneuromas and marfanoid habits, everted eyelid and thick lips. These are the characteristic features of meant to be. Um, but there is no any associated disease with the sporadic medullary thyroid carcinoma. Number of thyroid nodules seen in men 2A is they are the usually multicentric and bilateral. FMT also the FMTC also the usually the multicentric and bilateral. Men 2B also the usually the multicentric and bilateral, while the sporadic form is usually solitary nodule. C-cell hyperplasia present in all inherited uh, condition like men 2A, FMTC and men 2B, while usually absent in sporadic form. This is the cytological differentiation diagnosis of medullary thyroid carcinoma. First, the first entity is medullary thyroid carcinoma. The architecture patterns in isolated dispersed cells and syncytial-like clusters and amyloid mainly present. The cytoplasmic feature of medullary thyroid carcinoma is plasmacytoid epithelioid giant cells with spindle shaped cells or red purple granules with Romanovsky type stain. The nuclear feature of medullary thyroid carcinoma is round, ovoid or elongated with granular chromatin, internucleus pseudo-inclusion and binucleation sometimes seen. The immunocytochemistry positive for medullary thyroid carcinoma is calcitonin, CA, neuroendocrine marker, TTF1 and PAX8, while negative for thyroglobin. The follicular neoplasm, the characteristic architecture feature are they mainly the crowded seen in architecture feature mainly the crowded microfollicle, while the cytoplasm is scanty to moderate. The nucleus of follicular neoplasm is around hyperchromatic variable nuclear enlargement. The immunocytochemistry positive for TTF1, thyroglobin, PAX8, negative for calcitonin, carcinoembryonic antigen, and neuroendocrine markers. Next tumor is Hurthle cell neoplasm. The architecture pattern of Hurthle cell neoplasm is isolated dispersed cells and syncytium-like cluster. The cytoplasmic features of Hurthle cells neoplasm is abundant, finely granular uh, cytoplasm. The nuclear features of the cell neoplasm is round and elongated with moderate irregularity and prominent nuclear lysine. The immunocytochemistry positive for Hurthle cell neoplasm is TTF1, thyroglobin, and PAX8. The negative for calcitonin, carcinoembryonic antigen, and neuroendocrine marker. The next tumor is papillary thyroid carcinoma. The architecture form papillae sheet or in microfollicles. And the cytoplasm is variable depending on the subtype. The nuclear feature of papillary thyroid carcinoma is a classical nuclear feature like elongated or ovoid with irregular contour group present internuclear cytoplasmic pseudo-inclusion seen and chromatin is powdery or pale. The immunocytochemistry positive for TTF1, thyroglobin, PAX8, and while the negative immunocytochemistry for calcitonin, carcinoembryonic antigen, and neuroendocrine markers. Next tumor is hyalinizing trabecular tumor. The architecture pattern is cohesive cluster associated with hyaline matrix. The cytoplasmic features of hyalinizing trabecular tumor is epithelioid or spindle-shaped cytoplasm. And the nuclear features are enlarged with irregular contour group present internuclear cytoplasmic pseudo-inclusion seen and chromatin uh, chromatin pale seen. And the immunocytochemistry positive for TTF1, thyroglobin, and Ki67, negative for calcitonin, carcinoembryonic antigen, and neuroendocrine marker. The poorly differentiated thyroid carcinoma, the architecture pattern is crowded group, isolated, dispersed cells. Cytoplasm are scanty, occasionally plasmacytoid. The nucleus is round with variable enlargement and binucleation, and apoptosis and mitosis mainly seen in poorly differentiated thyroid carcinoma. The immunocytochemistry positive for TTF1, PAX8, and thyroglobin, while the negative for calcitonin, carcinoembryonic antigen. The next tumor is anaplastic thyroid carcinoma. The architecture pattern is isolated dispersed cells and the crowded group variable. Necrosis and inflammatory debris present mainly in the anaplastic thyroid carcinoma. The cytoplasm are epithelioid, spindle, or variable size. The nucleus of anaplastic thyroid carcinoma is enlarged with variable pleomorphism and nuclear prominence, multinucleation seen, necrosis and apoptotic and mitotic activity seen. The immunocytochemistry positive for PAX8, it also the variable positivity, give the variable positivity. The negative for TTF1, thyroglobin, calcitonin, CA, and neuroendocrine marker. The other tumors are the melanoma. The architecture pattern is isolated dispersed cells. The cytoplasm are epithelioid, spindle, variable size, variable melanin pigment seen. The nucleus is enlarged with prominent nucleoli. The immunocytochemistry positive for S100 protein and HMB45, Milan A positive, and SOX10 positive, while negative for cytokeratin, calcitonin, and CA and neuroendocrine marker. And the next tumor is parathyroid, metastasis from parathyroid. The architecture pattern is seeds or cord or acini form. The cytoplasm moderate amount often granular. The nucleus is round with granular chromatin. The immunocytochemistry positive for neuroendocrine marker PTH and GATA3, while the negative for calcitonin, carcinomembranous antigen, and TTF1 and thyroglobin. The next tumor is plasmacytoma. The architecture pattern is isolated dispersed cells. In this plasmacytoma, amyloid present. The cytoplasmic features are moderate amount with eccentric nuclei, plasmacytoid type, while the nuclear feature of plasmacytoma is round with granular chromatin, positive for CD134 and Congo red, negative for calcitonin, TTF1 and neuroendocrine marker. Next tumor is paraganglionoma. The architecture pattern is isolated dispersed cell and loose cluster. The cytoplasm is moderate to abundant amount of delicated cytoplasm. The nuclear feature of paraganglionoma is round with granular chromatin and an isonucleus is seen. The immunocytochemistry positive for neuroendocrine marker S100 protein, while the negative for cytokeratin and calcitonin. This is the picture of medullary thyroid carcinoma, predominantly dispersed plasmacytoid or polygonal cells having granular certain paper-like chromatin and a small indistinct nucleoli. A small fragment of amyloid is present. The arrow showing the amyloid. This is also the picture of the medullary thyroid carcinoma, a variety of shape round to polygonal plasmacytoid spindle shaped cells are seen. They are non-cohesive population pattern. This is also the picture of medullary thyroid carcinoma. The left picture is low power view showing the spindle shaped variant can have a syncytium like arrangement, and while the picture B or right picture showing the spindle shape variant has prominently interdigitating cytoplasmic process with oval nuclei, smooth nuclear membrane, granular chromatin and inconspicuous nuclei are maintained. This is the medullary thyroid carcinoma. Pigmentation of melanocyte differentiation can be seen in medullary thyroid carcinoma. The arrow picture showing the melanin deposition can be ruled out by the immunocytochemistry. If the medullary carcinoma of thyroid, the positive for calcitonin and TTF1, while negative for HMB45 and melan A. This is also the picture of medullary thyroid carcinoma with abundant presence of amyloid. This is the immunocytochemistry of medullary thyroid carcinoma. The upper left picture showing positivity for TTF1, the nuclear marker positive for TTF1. Picture B is positive for calcitonin, that is the cytoplasmic marker, and left picture C, left lower picture showing the chromogranin positive for medullary thyroid carcinoma, that is also the cytoplasmic marker, while the medullary thyroid carcinoma negative for thyroglobin, right lower picture showing the negativity. The next malignancy is poorly differentiated thyroid carcinoma. The poorly differentiated thyroid carcinoma was first proposed as a distinct subtype of thyroid malignancy by Karangui, who described a locally aggressive tumor with a peculiar architecture, tumor cells arranged in large round to oval formation, the so-called the insuliform. Currently there are two recognized subtype of poorly differentiated thyroid carcinoma, the insular form or non-insular form. This is the picture of poorly differentiated thyroid carcinoma. The monomorphic cells are arranged in crowded three-dimensional group and scattered as isolated cells. This is the poorly differentiated thyroid carcinoma. The architecture pattern is insular form. Endothelium wrapping with around cells group can be often be found. This is the HNE of the HNE section showing the poorly differentiated thyroid carcinoma. The cell block arrangement is in insular group form. This is the poorly differentiated thyroid carcinoma positive for cytoplasmic marker positive for thyroglobin. The next malignancy is undifferentiated or an undifferentiated carcinoma or anaplastic carcinoma. And the undifferentiated thyroid carcinoma, also called the giant and spindle cell carcinoma, is an extremely aggressive thyroid malignancy accounting for less than 5% of thyroid cancers. It carries the poorest prognosis of all, significantly worse than the well differentiated and poorly differentiated thyroid carcinoma. These tumors are rarely seen in individuals below the age of 50. There is a female predominance. Patient present with a hard nodular thyroid gland and most have a rapidly growing mass. Um, the undifferentiated thyroid carcinoma is a high-grade pleomorphic epithelial derived malignancy with epithelioid or spindle cells features. The criteria for diagnosis is the aspirate show the variable cellularity but are usually moderately to markedly cellular. Plastic cells are arranged as isolated cells or variable size group. Cells are epithelioid, round to polygonal or spindle shaped, range in size from small to giant size. Plasmacytoid and rhabdoid cells shaped are seen. Nuclei show the enlargement, irregularity, extremely pleomorphism seen, clumping of chromatin seen with parachromatin clearing and prominent irregular nuclei. Internuclear pseudo-inclusion also seen, eccentric nuclear placement seen, and multinucleation also seen. Necrosis is extensively present with inflammation. The neutrophils present as a inflammatory cells. The neutrophils infiltrate of tumor cell cytoplasm can be seen. The mitotic figure are often numerous and abnormal. The osteoclast-like giant cells are conspicuous in some cases. Tumor have the following immunohistochemical and molecular profile. It is mainly positive for PAX8. Sometimes the TTF1 and thyroglobulin are usually negative. But T53, CTN and B1 means beta catenin, and RAS and BRAF mutation also the marker also the negative. Sorry, these are uh, the V64 mutation also seen. The undifferentiated, this is the picture of anaplastic thyroid carcinoma. The neoplastic cells are mostly round. The mitotic, the arrow showing the mitotic figures. This is in the anaplastic thyroid carcinoma, uh, mm, showing the spindle shaped cells resembling like the sarcoma like features. The chromatin coarse, parachromatin clearing, and prominent nuclei seen. And the anaplastic thyroid carcinoma positive for PAX8. The next malignancy is squamous cell carcinoma of thyroid. The squamous cell carcinoma of the thyroid accounts for less than 1% of thyroid cancers. And the undifferentiated thyroid carcinoma, it occurs in the elderly and has a similar prognosis. The squamous cell carcinoma of the thyroid is malignant tumor that show exclusively squamous differentiation. The criteria for diagnosis is cytological sample are composed almost exclusively of large pleomorphic keratinizing cells. Necrosis may be present sometime. This is the picture showing the squamous cell carcinoma of thyroid. The sample is composed of large pleomorphic cells with conspicuous dense orangino-eosinophilic cytoplasm. There is abundant necrosis and nuclei show the degenerative changes. Thank you very much for listening.